Thank you for joining us for OrthoAlliance's OrthoInsights educational webinar series on sports medicine. Tonight's speakers are Drs. Desmond Stutzman, Rick Weidenbener, Molly Tatum, and James Sieradzki. Topics for tonight's webinar include hand injuries, overuse injuries in adolescents, conditions affecting female athletes, and how athletes cope with injuries. Speakers will answer questions following the presentations. Please type your questions in the Q&A box at the bottom of your screen. We will include all questions and answers on our OrthoInsights webinar series blog located at the OrthoAlliance website at orthoalliance.com. Our first speaker of the evening is Dr. Desmond Stutzman, orthopedic hand and elbow surgeon at OrthoNeuro. Dr. Stutzman will be speaking on common hand injuries and wrist injuries in sports. Dr. Stutzman?
Thank you, Heather. I'm sharing my screen here. Give me a second here. Technical difficulties. All right. There we go. Am I good?
You're good.
All right. Hi, I'm Desmond Stutzman. I do hand and elbow surgery at OrthoNeuro here in Columbus, Ohio, and I'm talking about common hand injuries that happen in sporting activities, and I've chosen kind of a case presentation, individual cases that kind of bring into light things that could happen, and then not so much that we're going to concentrate on the specific injury, but what other things you have to worry about, and when you really should seek the consult or the opinion of an expert. So the first presentation or the first case is a 16-year-old basketball player. It's probably happened to a lot of us, reaching in to try to steal a ball, jamming his ring finger. And the presentation's a simple one. It just basically some bruising into the finger, maybe some loss of motion, and depending on the severity of the injury, sometimes it could be very painful to the point where not so much pain at all. And so the first part of this talk in a simple finger sprain would be, is it broken? How do we tell? And really, for me, it's a no-brainer. X-rays are probably the most important thing when it comes to talking to an athlete after a bruising, loss of motion. It's just so hard for us to tell just with an examination. And there are several injuries that just seem to be a sprain. They linger, and then the patients come in to see me down the road, and it is in fact a complex fracture that requires operative intervention in order to prevent what these hands look like here. So finger sprains, back to finger sprains, just an injury to the collateral ligaments. Each joint in our fingers has a set of ligaments that brace the ligament or that brace the joint on either side. And these are the common injuries. A sprain, a simple sprain, swelling, bruising, as we talked. The more complex injuries are those that are on the volar plate. The volar plate is a ligament that actually prevents your finger from hyperextending. And these are difficult a lot of times in regards to the healing process, because it can take up to 12 to 18 months for these to heal. Sometimes there is even a little avulsion fracture that's associated with these. And so, again, simple sprains, I always feel they deserve an X-ray just to make sure that you're not dealing with something that is very, very difficult in regards to a complex fracture. And so our evaluations, X-rays, a lot of times we'll do stressing of the joints, because you can have a sprain that basically avulses an entire collateral ligament and create some instability. But again, for the most part, these are treated with very simple buddy taping. The return to activity is rather quick because we're going to obviously protect the fingers. In some of the higher contact sports, football, we'll place these patients into casts. And The one thing that I think everybody needs to hear is that a simple sprain, even though we say simple, I mean, sometimes you get some change in the joint, meaning that the finger could be large for a couple of months, maybe up to 6 months. And pain for that 3 to 6 months isn't uncommon. And so they're a significant injury in some of these cases, but again, X-ray is needed. Our next injury is a football player that tried to make an attempted tackle, pain, swelling on more of the distal end of the finger. That's typically where this will occur at. The patient has some difficulty making a fist. And the surprising thing about this injury that we'll point out is that, again, a lot of times the severity of the injury is not really recognized. And so this is called a jersey finger. It's basically an avulsion of the flexor tendon that attaches to the very distal end of your finger. Patients reach out, they're grabbing to grab a jersey. The ball runner rips away, and the finger's then forcefully extended, and that force then pulls the tendon directly off the bone. Ring finger is the most common, and that's just has to do with anatomy. Sometimes you can pull off a bit of bone with this injury. The most important thing is that this one is one that sometimes looks like a sprain. And bruising on the end of the finger is very typical, but as you see, it is urgent for recognition of this injury because reattachment occurs, or you want to place the tendon back to the bone within about 10 to 14 days. If you think of our tendons as rubber bands, and when they're let go from one end, they'll retract, and that's exactly what happens with these types of injuries. The tendon can retract into the wrist or the palm, and if it's there for too long, then you can't bring that tendon back out to the distal insertion point, and then it becomes a very complex and catastrophic injury. Explaining this a little bit more, there's two tendons that flex your fingers, and so this is why the injury sometimes gets overlooked. The patients are coming off the field, will make a fist, and if you're not careful, you see in this picture here, the patient's making a pretty good fist, but the attachment to that very distal joint cannot be flexed anymore. And if you're not paying attention to this, it can be missed because obviously this patient can't curl that finger. Their flexor digitorum profundus has been torn off, and that obviously urgency to repair that in about 10 to 14 days. So here's just kind of the idea of the injury. The picture on the right really depicts how we repair this. It is nothing more than opening the finger up, grabbing the tendon with some suture, and then I basically place a button on the end of the finger to tie the tendon down. That's held there for about 8 weeks. The patient starts a rigorous range of motion therapy, and then we just basically clip the sutures and take that button off at about the 8-week mark. They can't return to sports until 3 months. Sometimes I'm a bit paranoid, and may even be a little bit longer than that if they're doing the contact sports that we worry about, such as football or wrestling. Next injury is a common one. Patient reaching out to dig a ball in a volleyball game, had some bruising on the wrist, didn't really think much of the injury itself, waited a couple of weeks to come in just because of the pain started to become a little bit more severe with activities. Initially, it was thought that it was just a simple sprain, so nothing was done. But then when the patient came in, we take these x-rays that you see on the right, and what we're seeing here is a crack right through the scaphoid, the bone in the wrist that is very common in fractures, and especially a fall on an outstretched hand. These occur in almost every walk of sports where there's a chance for a fall. And the injury itself is very significant only in the sense that, again, there's urgency with this one, as you'll see later, that finding these patients early really can dictate different types of treatment protocols. And so This bone has a very poor blood supply. When it is fractured, when it's broken, the area of the fracture as well as the timing becomes very important. And so these are commonly misdiagnosed x-rays initially. And the difficult part about this is that sometimes the x-rays initially don't show the fracture. It doesn't really show up sometimes until 2 or 3 weeks down the road when this bone has started to go through healing, that we start to see the healing fracture line. And so again, that makes it very difficult. Patients with exams that really kind of exhibit this kind of worry, if we don't see any x-rays or any fracture lines by 2 weeks, they'll get an MRI or CT exam. The slide really shows kind of the trouble with this bone. The blood supply enters distally in this bone. And so when you fracture out on the distal end, it's 100% of healing. But as you go more proximal in this bone, that's where it becomes very tenuous in regards to the blood supply. It gets disrupted. The fractures that are even operated on sometimes are very difficult to get to heal. And so when you look at the locations, the farther the fracture, the more distal the fracture, the more conservative we are in our treatments. Maybe casting, as the fracture becomes more proximal, the blood supply becomes more of a worry, and more of an aggressive treatment is indicated for those patients. And so the timing is very important, because a lot of times if these fractures aren't diagnosed a 2-week period, a non-union is higher, meaning that the bone just doesn't heal. Because again, this bone needs to be rigidly casted or fixed with surgery in order to maintain that blood supply so it doesn't get disrupted. And again, unfortunately, this bone is probably one of the more important bones in the wrist. Without treatment on this bone, you're going to develop arthritis and obviously later complications in life. Very quickly, skier's thumb is a fall on the slopes. This one's a common one. Patients with a fall onto an outstretched hand. You can see here the area of where the pressure comes on the end of the thumb. It can rupture a ligament. This ligament, called the ulnar collateral ligament, is very important even when you're grabbing a cup. This can create a great deal of instability. We want x-rays, a lot of times even MRIs, to look at this type of injury. You can see here we're doing a stress x-ray, which shows that the ligament here has been disrupted. And this one is a surgical indication only for the fact that if this joint becomes unstable and is left unstable, you're not able to even pick up a cup, or bigger problems down the road with instability and then eventually the development of arthritis. Again, if we can treat this non-operatively, if it's just a sprain, then we cast it for 4 to 6 weeks, sometimes can take 3 to 6 months. Surgery, if there is gross instability, which is easily diagnosed just with an examination. And I'm rushing through this last one so I don't get yelled at. That's my 10 minutes. I hope you enjoyed it. Let me hear your questions.
Thank you, Dr. Stutzman. Our next speaker is Dr. Rick Weidenbener, orthopedic specialist at Midwest Center for Joint Replacement. He will be speaking on overuse injuries in adolescent athletes.
Thank you, Heather.
Can you see the screen?
I still have Dr. Stutzman's on my screen.
Sorry about that. I didn't want to stop sharing.
That's all right. I don't think you did that. Okay, there we go.
See now? Okay.
Yep, we're good. Okay, go to the first slide. I'm going to talk about injuries in adolescent athletes. And middle school athletes, high school athletes are not just smaller versions of ourselves. Physiologically and anatomically, they're quite different. And there are several predisposing factors that lead to different types of injury. in this age group. When we talk about weak tissues, we're talking about the tendons, ligaments, and muscles. Boys tend to go through growth spurts. Younger girls tend to grow more steadily, but when a young male athlete goes through a quick bone or growth spurt, the bones actually outgrow the tendons and muscles, and that's why teenage athletes are notoriously tight. Training techniques have a lot to do with injuries. A lot of times these are kids who are just starting out in sports. Sometimes they don't necessarily have the most experienced coaches teaching them techniques. And you can run into a lot of overuse type of things with training errors. And again, kind of like the growth spurts, the bones outgrow these soft tissues, which can result in a lot of tightness and inflexibility. And that, of course, predisposes to injuries. Biomechanics can be muscle imbalance, muscle weakness. It can be angular deformities of bone. And I think Dr. Tatum's going to talk most likely about the female athlete triad. Next slide, please. So in a growing bone, there are different parts than we have in our adult mature bones. The growth plate seen here on this slide is called the physis. That's the active area of bone growth and elongation. It's more or less the weak link in this whole chain. The epiphysis is toward the joint side. On the other side of the physis, then you have the metaphysis also. This is an x-ray of knees, of course. The wavy lines are the growth plates. Next slide. This is probably the one slide I hope you just keep in your memory. And again, as I said, middle-age or middle school and high school athletes are not just smaller versions of ourselves. Peak bone density does not occur until we're close to age 30. Boys reach a higher peak density than females. At the time of menopause, bone density drops off in females and then smooths out again. Males tend to just have a slow, steady decline after the age of 30. So if you look on the bottom axis, look at about age 15 years, and if you take a vertical line from 15 years across, you'll see that the bone density of a 15-year-old girl is really about the same bone density as a 65 or 70-year-old woman. Similar to boys, their peak bone density in their teenage years is nowhere close to where they're going to be at peak, and again is equivalent to an elderly person. So this is the one thing that middle school and high school coaches sometimes just don't get. They think you have a young, healthy athlete, their bones are strong, and you can run them into the ground. But that is not a good idea because skeletally immature kids are prone to stress fractures, which we'll talk about. Okay, next slide, please. We'll kind of go head to toe. Each joint, we could probably talk about 5 or 10 different type of overuse injuries. I'm just going to touch on one per joint because of time constraints. You know, shoulder problems, rotator cuff, labral tears, everybody thinks about those, but a lot of shoulder injuries actually start on the backside around the scapula. Scapular winging is a condition. It can be from a nerve injury, but more commonly it is due just to some muscular imbalance. And when the muscles around the scapula do not work properly, there is a great deal of stress on the shoulder joint itself. So when we treat shoulder injuries, we don't just treat the shoulder joint, but we treat the area around the scapula as well. Next slide, please. The picture on the left is an MRI of epiphysitis. Epiphysitis basically means irritation of the growth plate. And you can see that in throwing athletes. You can see it in swimmers where overuse leads to not necessarily disruption, but irritation of the growth plate, which can lead to dysfunction. And the X-ray on the right is just a normal growth plate. Then the next slide. If this condition goes on as an unrecognized condition, the growth plate can actually break down and widen, where you see a stress fracture basically through the growth plate with a widened physis. And that's important to recognize because if that goes unchecked, you can actually get premature closure of the growth plate, a limb length discrepancy. You can get angular deformities if it displaces. Okay, next slide, please. Moving down into the elbow, people are familiar with the, quote, Tommy John surgery. That involves the ulnar collateral ligament, which is on the inner part of the elbow that connects the humerus, the upper arm bone, to the ulna. And in throwing athletes, where you get a lot of what we call valgus stress on the elbow, that ligament can get stretched out. And over time, it can get stretched enough to where you start to get compressive forces on the opposite side of the elbow that can lead to cartilage problems there. Gone unchecked or with one particularly bad throw, the next slide will show you what can happen where the ligament actually pulls the growth plate off. Next slide. When it is displaced that much, that requires surgical fixation. Moving down the arm to the wrist. A lot of athletes have full weight bearing on their wrist. Gymnasts, cheerleaders, tumblers, weight lifters, when they get their wrist bent back a lot with the bar, like with a squat or a power clean. And impingement can occur. Impingement occurs when the joint capsule gets pinched, when the wrist is in what we call a dorsiflexed position. Dorsiflexion is where the back of the hand comes toward the forearm, and it tends to get hyperextended at times, especially with weight bearing. The middle picture there shows us the carpal bones where they come together with the radius and the ulna. The impingement occurs on the backside of the wrist. That's a typical overuse type of injury in athletes who spend a lot of time weight bearing on their wrists or with a weighted bar. Okay, next slide. Not just can you get impingement, but the growth plate on the end of the radius, the one forearm bone on the thumb side, can get, just like in the shoulder, you can get a stress syndrome there. These areas depict the area on the MRI where that stress has occurred on the growth plate at the end of the radius. Next slide. So moving down the spine, this is a big problem with a lot of different athletes. This is what we call spondylolysis, which is a stress fracture of the pars interarticularis. The pars interarticularis is the part of the vertebrae that goes between the part of the vertebrae that articulates with the vertebrae above and below. In athletes who have a lot of hyperextension, divers, gymnasts, cheerleaders with tumbling, offensive linemen coming up in extension, soccer players with torsion. Repeated hyperextension leads to these types of injuries. If these stress fractures occur on both sides of this arch, and we'll see that in the next slide, you can get what we call spondylolisthesis, which is where one vertebrae slips on the other. In this picture, if you want to go back real quick, Heather, the vertebrae are the bony white parts. The discs are the blue objects in this diagram. Once you get spondylolisthesis and slippage of one vertebrae on the other, the disc in between obviously can get damaged quite extensively. Okay, the next slide shows a unilateral pars stress fracture that we call, if you picture on the opposite side where Heather has the cursor, then it becomes just disjointed. That can result in the spondylolisthesis where one vertebrae can slip on the other. That not only gives back pain, but if you have slippage, you can get nerve impingement, sciatic type pain, and that sort of thing too. Next slide. The X-ray on the left shows normal alignment with this stress fracture. On the right, there has been some slippage of the last vertebrae on the sacrum, L5S1. That would have to be a bilateral stress fracture in order for it to actually move. But that's spondylolysis leading to spondylolisthesis. In the hip, there are lots of overuse type injuries. There are lots of growth plates. Probably the most serious thing we see, this is almost exclusively in runners, are femoral neck stress fractures. What you see in this picture is On the left, that red line is on the lower side or the compressive side of the femoral neck. That's a better place to have your stress fracture. If it's on the opposite side, the tension side, those generally don't do well without surgery. They can go on to non-union. But again, these are overuse injuries, not uncommon in high school runners. Next slide. This is an MRI showing the stress fracture on the compressive side, the white area in there. Osgood-Schlatter syndrome, most people have heard of that. That's a condition where the tibial apophysis, right there where the cursor is, the patellar tendon attaches there, and with repeated running, jumping type activities, the tendon can pull that growth plate, this part's called an apophysis, apart a little bit. In this particular X-ray, it looks like there's been a little fracture through the apophysis, and up on the side view of the kneecap, you actually see that's another condition much less common called Sinding-Larsen-Johansson syndrome, where you can have a little avulsion of the apophysis on the patellar tendon. But basically, Osgood-Schlatter syndrome, very common, growing athletes, growing kids. Once growth is finished, the growth plate closes. Sometimes you're left with the residual bump there, but the pain goes away when growth is finished. Next slide. Patellofemoral syndrome, very common problem, especially in teenagers. It's sometimes due to malalignment issues, more frequently just muscle imbalance. You know, when we run and jump and bike, weight train, we're usually working two parts of our quad that strengthen the middle and outer part. The little muscle on the inside called the VMO is the one that really controls the tracking of the patella. And when that gets weak, the kneecap tends to track to the outside. In patellofemoral syndrome, the athlete will have a lot of pain in the front of the knee with lunges, squats, climbing stairs, jumping, and that sort of thing. Rehab, strengthening the VMO in particular, usually takes care of that problem. Next slide. Medial tibial stress syndrome, commonly referred to as shin splints. That's kind of a broad generic term where the muscles that attach to the bones in the lower leg irritate the what we call the periosteum, which is kind of the outer soft tissue layer of the bone. It can occur in different parts of the tibia. Now, shin splints and stress fractures are on the same continuum. Gone unchecked, shin splints frequently will lead to stress fractures, and the next slide has an X-ray of that. You see the dark line there. The X-ray on the right actually has 3 dreaded black lines, as we call them. Next. Biomechanics of the foot and ankle can affect not only the foot and ankle, but affect the knee, the hip, and the lower back. Pronation is probably the most common ankle biomechanical abnormality where the ankle tips in. You can see that on the left. Neutral is straight up and down. Supination is the opposite of pronation, where they would actually walk more on the outer part of their foot instead of collapsing to the inside. But again, in evaluating back, hip, knee problems, you always have to look at the gait pattern too, because oftentimes it starts at the ground. Next. Seaver's disease, similar to Osgood-Schlatter, is an irritation of the growth plate. That occurs a little bit earlier in kids. The growth plate you see on the back of the calcaneus, that's the heel bone there, gets very irritated. Usually it's fairly easily treated just with some heel pads and maybe some activity modification. Next. Stress fracture of the feet occur. Again, oftentimes, just like Dr. Stutzman mentioned early on, sometimes a wrist X-ray will not show the scaphoid fracture. 2 or 3 weeks later, we see the sign of that fracture. So this is an X-ray on your left, which has a stress fracture that you can't see. 2 weeks later, you see the bone healing, the callus around that. It's quite apparent within a couple of weeks within a growing athlete. Next. So what do we do to prevent this? I mean, it's really an awareness thing of parents, the athletes themselves, and especially their coaches. Things have evolved a lot since I was a teenager in the 70s. You know, we used to play maybe 3 sports, but they would never overlap, and we would never play anything year round. That obviously has changed a lot. Generally, it's recommended that an adolescent athlete not subspecialize and just stick with one sport until they're at least 13 or 14 years old. Growing up, they should be involved with different sports, different stresses on the body. One thing all year long can lead to these types of injuries. And then, of course, there's overlapping seasons too, which is a problem. But again, that's sometimes a fight between coaches. Growing bodies need rest and recovery, even more so than adult bodies. Nutrition is important, not stressed that much in high school athletes. Unfortunately, that really should fall back on the parents to make sure they eat right at home, get enough protein, get enough calcium and vitamin D, especially with their growing bones. Next slide. So prevention and the spine. Again, with the spondylolysis, it's hyperextension type of injuries. It's really important when young athletes start weight training to weight train properly, not get into too much hyperextension. For the spondylolysis, I mean, things like leg presses, leg extensions can be substituted. Diet and eating disorders. I think Dr. Tatum will probably touch on that. Core strength is important in all sports, probably the most neglected part of strength training. I mean, most people don't realize it, but a pitcher throws hard because of leg strength, not arm strength. The only way to get your power from your legs to your shoulder is through your core. Next slide. Rotator cuff problems, common in throwing athletes, common in swimmers. I think every throwing athlete should probably be, a young athlete, should probably be on a year-round basic rotator cuff strengthening and parascapular strengthening program with the TheraBands. That will prevent almost all of these shoulder injuries. In younger kids, to avoid the growth plate injuries, pitch counts are very important. And the website I have up there is actually a very good resource for coaches and parents. It kind of gives throwing progression at different ages through maturity till college age. And again, as we talked about, core strength is critical to throwers. Next slide. Runners. Is there anybody who treats sports injuries? You see all these stress fractures in August because the cross-country kids quit running after track. Suddenly they're running 5 or 6 miles a day. They don't build up. They get stress fractures. Monitoring the mileage is important. And again, these younger athletes are not just smaller versions of ourselves. They're skeletally immature. Nobody would suggest to a 70-year-old woman to go out, run 70, 60, 70 miles a week. But some coaches think their teenage runners should be doing that. But they need to understand their bones are not up to the task. Again, biomechanic, looking at a gait pattern, whether they pronate, supinate, whether they're neutral. Footwear is important. Even the best running shoes wear out after about 400 miles. You know, for biomechanical issues, I always tell the parents, just get a neutral shoe. We'll get you an orthotic, whether it's off the shelf or custom, depending on how bad it is. But a neutral shoe with the right foot bed is probably better than buying a shoe for supinators or pronators. Stretching, again, through growth spurts. Kids, teenagers get tight. They can never stretch too much. They need to stretch before and after. Coaches, again, hopefully can educate themselves. Sometimes it takes the whole team to talk to them. That's the athletic trainer, team physicians. Of course, coaches don't like to listen to parents usually, but parents still can educate coaches in some ways if they're tactful. Again, for younger adolescent athletes, coaches need to allow for other sports. You know, sometimes they get very territorial, but having the overlapping seasons and year-round club sports is hard on a growing body. Sometimes the parents have to be kept in check. Okay, next. And I think that's it. I don't know where I stayed on my 10 minutes, but I hope I got close.
Great, thank you. So our next speaker is Dr. Molly Tatum, orthopedic surgeon at Orthopedic Institute of Dayton. She will be discussing Conditions affecting female athletes. Dr. Tatum?
Thank you. All right, so this evening we're going to talk to you and focus kind of on the female athlete. The female athlete is definitely different than the male athlete, and we are learning over time how injury patterns and injury prevalence is very different between the genders. A lot of this data is extrapolated because back 100 years ago, we did not have a lot of data on female athletes, as female athletes were not that common. Many of our data and large studies are from military data, and most of these are male predominant studies. So we're learning over time some of these differences. Oh, just to give a kind of brief history, the first Olympics was held back in 776 BC. The first woman that was allowed to compete in an Olympics was in 1900. So you can do the math on that about how long it was before women were permitted to be a part of the Olympics. And for many years, women weren't even allowed to watch them. So big difference from, this past summer where we got to see many amazing female athletes perform. Title IX back in 1972 changed a lot for women, not just women, but girls and young females. Back before Title IX, 1 in 27 girls played high school sports. Now it's less than 2 in 5. So there's a very, very big increase in girls and females being involved in athletics. And that was only 50 years ago. What have we learned over this time? Overall, the risk for females is higher than it is for men to just have any injury during sports. There are many injuries that are specific for females to be higher risk: ACL tears, anterior knee pain, chronic ankle sprains, hip pain. Many of these have common denominators that I'll discuss, but we need to pay attention to these things and be ready to treat them. So why does this happen? Women have different anatomy. We have wider pelvises. We have increased femoral anteversion. And what that means is our hips are more rotated inwards. And this increases our Q angle, which then can put more stress on the kneecap area. Overall, we are relatively more lax in our joints than males are. And we have less average muscle mass after puberty. If you look before puberty, males and females have a lot of the same muscle mass. And then as females go through puberty, we actually develop more fat and it's harder to gain muscle mass, where males start gaining more muscle mass easier. ACL tears, this is a very high incidence in females, more so than males. Some statistics will say up to 7 or 8 times more likely for a female to tear their ACL. Most of these are non-contact. Another key point is that females are less likely to return to competitive athletics after injury. Why? We are still figuring that out, and it's a big area of research, and we have understood some of it, but not enough that we can prevent it and get these data down to equivalent. In general, the ACL is smaller in females. Growth changes through puberty. The males in general, their femoral condyles, which is where the ACL attaches, enlarges. The notch also enlarges, where females it does not as significantly. Males gain more muscle mass in puberty, so they think that they can compensate better. The Q angle is larger on average in females, and they talk about this position of no return. If you look over to the right side of the screen, you can see that there is the pictures, and the female knee is starting to point inwards towards the other leg instead of coming straight ahead, and that is what we call a valgus force. That's usually how the ACL tears, and this is a lot of landing mechanics that can be strengthened in women to try and help prevent injury. There are some hormonal concerns. The estrogen receptors found in human ACL fibroblasts, and they feel that this can reduce collagen synthesis. And there's a chance that as women develop more estrogen going through puberty, that could be a potential reason they're more likely to tear their ACL. Why do we care about this? These x-rays all show the bad outcomes associated with ACL injuries. A lot of people are very concerned about getting the athlete back to sports. I have very long conversations with the patient and the parents that my goal is to get them as normal of a knee as possible, that their knee went through a very large injury, and the bone bruising and all these changes we see on these imaging before we even talk about surgery, sometimes that injures the cartilage at that moment, and then they develop x-rays like this from 5, 10, 20 years down the road. And if you have a teenage athlete, and then you're talking about, oh, 10, 20 years down the road, that only gets them into their 20s or 30s before they're talking about joint replacement surgeries. So these are very big injuries, and we need to focus on trying to decrease our chances of developing arthritis at a very young age. X-ray findings show that about 10 years after an ACL injury, about 50% have signs of arthritis. Once you get to 15 to 20 years, all patients have signs of arthritis. It doesn't mean all of them are symptomatic, but if you take x-rays, you can start to see some changes. Patellofemoral knee pain, extremely common thing that we see in our office as orthopedic surgeons. It's pain kind of just diffuse around the kneecap, always complains of pain going up and down stairs. Many times going downstairs is worse than going upstairs. Pain with lunges, deep squats. About 25% of all knee complaints that comes into the office is patellofemoral pain syndrome. It is twice as common in females than it is in males. Why? Same reasons as the ACLs: increased Q angle, poor mechanics, quadriceps dysfunction, wider pelvis, decreased muscle mass, and weak hip abductors. So a lot of these things potentially are preventable, but you need to work on them. Another thing that is common is hip pain, hip dysplasia. Hip dysplasia means that your hip socket is not as deep as it should be to cover the ball. About 4 times more likely for females to have hip dysplasia than males. And this allows the capsule to have more laxity. It makes females really good gymnasts, really good cheerleaders, divers, but it can increase strain on the cartilage, and it can increase the pressures on the cartilage, as well as lead to labral tears, and then they develop early arthritis. So in this x-ray in that bottom corner, you can see how the ball sitting in the socket, about half of the ball is uncovered. So that shows you that this is hip dysplasia, and it's on both sides. Trochanteric bursitis, very, very common for a lot of women to complain of pain on the outside of their hips where that bony prominence is, which is called the greater trochanter. But in reality, we've learned over time that it's not really so much trochanteric bursitis. Greater trochanteric pain syndrome is probably a more appropriate term for this. This is about 4 times more likely to be a complaint from a woman than it is a man. And many times it is more gluteal tendinopathy than it is trochanteric bursitis. So most common in ages 40 to 60 years of age. Some of these studies have shown that a tear of these tendons can occur in about 25% of middle-aged women and up to 10% of middle-aged men. So that's not a small amount of people. So watch people walk. Anytime I see women with these, I say, watch at church or go to the grocery store. People don't go to the mall as much before like they used to, but if you just watch older women walk, many of them waddle. And it's not because they're trying to be cute. It's because they can't stabilize their pelvises when they walk, and they have weak hip abductors. So you can see in this skeleton model, when they go on one leg, that pelvis drops. The problem is not on the side that is dropping, it's on the opposite side. It can't stabilize that pelvis. That's called a Trendelenburg gait. There's a higher incidence of gluteus medius tendon tears in these patients that have intractable pain, or they're not responding to typical trochanteric bursitis type pain. So that's when we need to look to see, is there a glute med tear? MRI studies have shown that about 45% of individuals who did not respond to trochanteric bursitis treatment actually had a tear. And only 2 out of the 24 that were MRI'd actually had any evidence of trochanteric bursitis. So if you're not responding to treatment, need to ask a little bit more. I mean, this is just an injury waiting to happen. You can just see how those legs are coming together. When they land, is putting more stress on ligaments in positions they don't want to be in. And then you can see how that pelvis is dropping and everything is just not working the way that it could in a better manner. This is a way to test gluteal abductor strength and external rotation strength. We touched on a little bit earlier about the female athlete triad. A couple years ago, they decided to update the name to relative energy deficiency in sport, also known as REDS. This is unbelievably common. They say that in high school athletes, about 78% have one component, and you have to ask the right questions. And sometimes it gets awkward when I ask girls about their periods and their eating habits. But it's really important because you see a lot of stress fractures, you see a lot of stress reactions, and these things don't get fixed quickly. So you have to really ask questions. The other thing is you have to ask about vaping. You have to ask about nicotine use. You will be shocked at some of these young athletes when I say any nicotine, and they look down or they look away. And then, you know, a lot of them are vaping, and a lot of that does have nicotine use in it. And nicotine definitely decreases bone health. So, and the problem, as I alluded to, is that these things can't be fixed quickly. So when you have somebody that's not eating enough, that's probably the easiest thing to fix. Having a sports nutritionist available can be so helpful because it's not just telling, you know, somebody who has disordered eating patterns, you need to eat more. You have to really figure out what do they like, when do they need to eat. Many of these high school athletes do not eat well, and then they end up having problems. If your girls are having dysmenorrhea, amenorrhea, this is something that can take months to recover. The bone density is what takes the longest, and you need to look at what their bone density should be for their age, and not just getting a bone density scan and saying, oh, we don't have osteopenia or osteoporosis. They can have low bone mineral density for their actual age. Concussions is another big thing. There's a lot of media coverage for football and concussion and the risk with that, but they occur in a lot of sports. Female athletes are more likely to sustain a concussion during games than male athletes in comparable sports. Most common for female athletes is soccer. Soccer is very high risk for girls. That study in Michigan showed that girls were twice as likely to experience concussion than male counterparts in the same sport. It's a big problem that most of the research has been done on males. So trying to figure out concussion symptoms, concussion responses between males and females, or extrapolating the data from the males and assuming that's how females respond. You can look at this and see that about 80% of the data comes from male studies. So is that accurate? We still need to figure that out. And there was only a couple studies that actually just were of women. We figured out over time that women have different heart attack symptoms and different presentations. So we need to make sure that we're appropriately evaluating our female athletes in the same way as we do our male athletes. In general, the concussed female athlete has greater neurocognitive impairments. They have more total symptoms, they last longer. So this definitely needs to be addressed. A review of the 25 studies of sports-related concussions shows that females were not only more susceptible to concussions, but they also had more severe symptoms. So we need to pay attention to this. So if a female is complaining of symptoms longer, it's not because they're necessarily saying that they don't want to play. It's because they respond differently than their male counterparts do. So some take-home points: male and female athletes, their injuries are not always equal. We need to treat them individualized, just like we do every patient. We have limited information regarding this. We only have, you know, a few decades of real literature on this, so we're going to learn a lot more over time. Many knee injuries are potentially preventable. We need to work on proper strength training, landing mechanics, and you need to sometimes guide individuals on sports. You know, you'll have some people and you watch them walk, you watch them land, and you just know they're a walking injury risk. So kind of putting them into some strength training and guiding them can be very helpful to hopefully keep them from coming in with that acute ACL tear. Trochanteric bursitis, if it's not going away, that needs to be looked a little bit more into. Proper nutrition is extremely important in these young athletes. Ask the hard questions. It's okay if the doctor can't ask them, who is supposed to be able to ask them. So, I always tell my athletes, I'm here to treat you as a person. I'm trying to get you back on the field and back on the court and back doing what you want. But sometimes that is looking at you as a whole person and not just treating that specific injury. Concussions in women are serious. They need to be looked at. They need to be studied more. And we need to make sure we're doing everything we can to prevent them. Thank you very much for your time.
Thank you, Dr. Tatum. Our final speaker of the evening is Dr. Sieradzki, orthopedic surgeon at South Bend Orthopaedics. He will be speaking on how athletes cope with injuries. Dr. Sieradzki.
Yes, sorry. So thank you for the opportunity to speak to you all this evening, and we'll try to keep this relatively brief because I know we're running a little bit over. My name is James Sieradzki. I'm an orthopedic surgeon from South Bend, Indiana. Practice at South Bend Orthopaedics. I'm a sports medicine specialist. And next slide. And so I have some specialized training in sports medicine, and then do some orthopedic coverage for all levels of athletes, including Notre Dame teams. And so we're happy to have the opportunity to do that. Next. So in terms of how athletes respond to injuries, I think you could think of this in either the physical sense or the emotional and mental response, and I think we'll focus a little bit on both. Certainly the physical response is sort of the first thing that happens. We have the athlete injured on the field. It's an emotional event for the fans and for the athlete. There's a lot of pain. There could be swelling in the joint. And there's immediate kind of treatment, on or off the field, including immobilization and crutches or a sling, to kind of get the athlete off the field and then maybe back home. As team physicians, we often have to deal sort of with this acute phase of trauma in terms of, pain management. Obviously, narcotics are somewhat taboo in our field, and we're trying to minimize them as much as possible because of, addiction problems and other issues. But certainly there are some role for those type of medicines in the acute phase of severe injury. Next. Now, not all athletes respond similarly to an injury. There can be varying degrees of pain with similar fractures or ligament tears, different amount of swelling in the joint or in the leg that can occur with, again, what looks to be the same injury on X-ray or an MRI. And some folks will develop muscles that will deactivate or not work after trauma and take a while to kind of come around and work again. And pain management can be a little bit, of a variety, meaning that some people have very little pain, require no medicines, and others, quite a bit. And we have to manage all that in the sort of immediate phase of an injury. Now, obviously, the first phase of any injury is sort of kind of figuring out what's going on, and it's helpful for any major injury on a sport. In a sport or at a high level athlete, that they seek, consult from a sports medicine specialist. Oftentimes that'll involve some imaging, including an X-ray or an MRI. And after we have sort of all the data and examine the patient, they're going to get the big news, in terms of what does this mean? What does this involve in terms of healing? What time frames are involved in terms of getting back on the field or the court? And then obviously there's a lot of discussions with family in terms of, what the type of injury is, what the options are in terms of treatment. Is this something that requires surgery? Is it something that could heal in a cast or a brace? And as they're kind of getting this information, there's this evolution of the pain, swelling, and inflammation that's occurring at the injury site. And, and all along we're sort of planning for the future, how are we going to get this athlete, back on the field? And they want to know the same. Next. So I think the most important thing up front is to get a plan in place. And I think every athlete is sort of dedicated to their sport. They spend quite a bit of time, practicing and rehearsing and training and building muscle and focusing on their nutrition. And then all of a sudden they get injured and, they have to sort of take a step back and see, how do I get back to where I was? And so they really want to know, what are the ins and outs of my injury? They want to know what it takes to get back on the field or court, and they want to know, how to do that the most quickly. And so, a lot of education is involved in terms of the type of injury, like to review images, MRIs, X-rays, with the patient so they really understand it, and then also understand kind of what is required to kind of get them back to full activity. And a lot of the things up front are, pretty simple. We need them to rest. We need them to get good sleep. We need them to ice and elevate their extremity. We need them to get proper nutrition, and then really focus on the initial rehab protocols to kind of get those muscles working again, whether or not surgery is required. Next. Now, obviously, we as physicians need to recognize when there's a poor response to, immediate injury or trauma. That could be excessive pain that's not controlled. It could be a nerve injury that's causing excessive pain that we can't quite understand. Scar tissue can form that can prevent mobility in a joint or a muscle tendon unit. And so we need to be on top of that in terms of getting that treated so there's no long-term consequences from the injury. Obviously, we want to make sure the muscles are working properly and that the body's tuned up for full recovery. Next. So if we do see an abnormal response, we need to alter the rehab program. We might need to add different modalities, different treatments, different ways to get the muscle and joint, to act more normally and recover in a quicker fashion. Sometimes we need to change medications to treat sort of nerve injuries or other pain responses that might be affecting an athlete. And in rare cases, we might even have to do a surgery to sort of combat the consequences of severe injury like scar tissue. And obviously always trying to promote good nutrition as an athlete heals. Next. Now, the emotional response is probably the bigger thing. I think this is probably the thing that, really determines whether someone gets back on the field or gets back to the same level of play that they were. The responses are not always uniform, for a specific injury. It's very athlete specific. It's very injury specific as well. I mean, some injuries are more severe than others, and they, can recover at different rates. Obviously, the response to the injury can have positive and negative impacts on a patient's psyche long term. Next. So the emotional responses to athletic injuries are kind of well documented, and there's several sort of lists of them. I've sort of listed the American College of Sports Medicine, list of responses to athletic injuries, and some of these are going to mimic what you might see for major trauma in one's life, loss of a loved one, or loss of some major love in your life, and that can lead to a lot of things that are potentially positive and negative, depending on how someone responds to them. Next. And so the emotional responses, can really affect the physical recovery to an injury. So if someone becomes, depressed or sad because of the injury and their inability to play their sport, that can affect their sleep. It can affect what they're eating. It can affect their nutrition. It can affect their overall recovery. And then obviously they may not have the motivation to do the proper rehab, to get that, muscle, joint, or injury back to 100%. Some patients and athletes will, suffer from substance abuse after a major injuries, and that could be due to depression. It could be, from a narcotic that was prescribed, or it could be just, like I said, a sort of abnormal and inappropriate response to trauma. And we need to be mindful of that and kind of be wary that can happen, and be, there to support an athlete and kind of provide the appropriate treatment when necessary. And any athlete, they need, again, proper motivation to recover, and that, it really requires a team approach. It means the sports medicine physician, helping them understand what the injury is and how to recover, family and friends, coaches and teammates, those people can be involved in trying to motivate an athlete to get back to their level of function. Next. And so, like I mentioned, a team approach is critical when we're getting someone, back on the field. A nutritionist, at high levels of sport, in the collegiate and professional realm, certainly we have, nutritionists that help our athletes, have peak nutrition, when they're performing, but then also really working on the nutrition if they're recovering from injury, because that is so important in terms of decreasing inflammation in the body, decreasing swelling in the body, and also helping with healing of, muscles and tendons, during the recovery process. Also, it can be helpful to have, the services of a mental health professional, especially if someone has an abnormal response to their injury or trauma, whether that be depression or anxiety. Having them, have someone to talk to is critical. And obviously, family support and friend support, being kind of surrounded by loved ones is really key, because I think everyone sort of surrounds the athlete during that initial, injury on the field, but then, during the weeks and months that come after, where there's a slow recovery and slow return back to sport, there's less support. And so I think we really need to focus on kind of surrounding them with that support during the entire recovery process, which can be up to a year. And obviously the teammates and coaches are involved with that. And we as, team physicians need to be cognizant of that. Next. So, as, team docs and managers of teams, really need to monitor these athletes for signs of problems. And that can be something very simple as a change in diet, whether that be, excessive eating or not eating properly, or limited nutrition. That can really be a sign that someone's emotionally not responding well to their injury. Sleep patterns also need to be, watched, because disrupted sleep can really prevent healing, but also it's really a sign of an underlying problem mentally in terms of their response to the injury. Rehab performance, obviously we're always following that, in terms of how they're recovering. But we need to understand that the rehab performance may not be just because they don't want to do it. It's just that they, again, mentally aren't prepared to do it, and they need to have the proper support to do so. So, at again, high levels of sport, collegiate and professional, certainly there's baseline metrics for all this. So all the athletes at Notre Dame will have, daily check-ins or weekly check-ins in terms of their sleep habits, nutrition, and sort of physical output. And so we kind of know where they are at baseline, and then, can follow that during an injury pattern and understand, when they're off their baseline in terms of nutrition and sleep, and kind of, intervene, with a mental health professional or whomever is needed to kind of get them back on track. Next. So we'll go quickly through a couple, injury types that I think, we see often on the field. I mean, concussions are one of those things that, are very, very common. And they're not necessarily treated by orthopedic specialists, but we see them all the time if you're a team physician. And it's kind of interesting, how these occur. They're not always a high energy event. We always think of a concussion as being, the head-to-head hit where the player goes down and is unconscious on the field. And occasionally, and often that is a concussion, but oftentimes there could be very, very mild trauma that leads to concussions. And, I've seen a lot of low energy sort of, little bumps on the ice or little bumps in the field that seem like it would not have caused any major trauma actually lead to concussion symptoms. And the severity of the concussion can vary. It really isn't predicted by the severity of the trauma. It's more based on how quickly it evolves afterwards. And that's, like I said, very unpredictable. And obviously that unpredictability is difficult for an athlete. They want to know, when will I be back? How long will this take to heal? What do I have to do to get, back where I was? And for concussions, it's really hard to tell. It's a sort of a day-by-day thing, week-by-week thing. You're sort of monitoring their symptoms, and there's very little intervention. And so there is certainly a risk of an athlete becoming depressed when they're kind of going through that, because they, just don't have a lot to do. They're just sort of waiting on the sideline for their brain to rest, essentially. Next. And so again, the mechanism of injury varies with these concussions, and the treatment plan is very difficult, especially for the young, adolescent athlete or collegiate athlete. Essentially we're telling them to stay off their screens, stay off their phones, avoid any, bright lights, stimulation, avoid exercise, and if they're an athlete, that's extremely difficult, and other substances should be avoided as well. So again, a tough thing to recover from, and something that, can sometimes sideline an athlete forever if they've had too many of them. Next. And so we'll just review, a couple quick cases to sort of review the kind of responses to injury. This was, a young athlete, had the pleasure to see during a great career, and had just multiple injuries to one knee, essentially time and time again, injuring the knee in terms of developing injuries to the meniscus, the cartilage, the ACL, all the major things that you can think of happening in the knee happened on multiple occasions, and had multiple surgeries over several years, and was able to come back from almost all of them. Then eventually, it got to the point where you just kind of wonder if this is going to be the right thing. Is it proper for us to continue to try to rehab the knee and get an athlete back out to sport if they continue to re-injure it in some new way and require abundance of rehab? And then like we just saw with the ACL injuries, there's a risk of developing arthritis after one ACL tear. And if you're talking about multiple injuries, multiple tears, is it really right to keep going? And at some point, it's always obviously up to the athlete what they want to do, but sometimes they just don't know maybe what's right to do, and they have to know kind of what things look like at 10 years, 20 years, and 30 years down the road. And I always tell the athletes I take care of that I don't work for a team or a university. I work for you. My job is to get you better now, and my job is also to have you functioning at the highest level in 10 years, 20 years, and 30 years down the road. And sometimes that's a frank discussion to say, hey, maybe the risks of sport are too much, and we shouldn't keep doing this. And obviously that's difficult to hear. And obviously it requires multiple conversations, and with the the team physician, the training staff, coaches, and then obviously friends and family to kind of come to that eventual conclusion. Next slide. And so after all these sort of severe problems and difficult situations, we'll kind of end on one sort of happy note. Now, this would be sort of the response to ACL tear, and that again varies across athletes and varies across sports, and then not all ACL tears are the same. There's different things that can happen in conjunction with it that can slow recovery. So you can hear recovery times back on the field anywhere from 6 months to a year plus, depending on the severity. And so that definitely varies, and it varies based on the athlete's kind of dedication, I believe, a little bit, in terms of their recovery as well. But we had one athlete who had, a ACL tear early on in their career and was able to come back, but it took a while. He actually, frankly, would say, I just wasn't as dedicated to my rehab. I wasn't as focused on it. It's just kind of going through the motions, and, it took him roughly 11 months to get back to full activity. And then roughly a year and a half after that, he tore his ACL in the opposite knee. So new injury, new knee. He's already been through it. Is it, how's it going to go? And it was a total, 180 degree, different approach to the injury. He was sort of 100% dedicated to, nutrition, to sleep, to his focus on the rehab, and his strength improved, much quicker. He had much less swelling because I think, the nutrition was better. He was, he didn't have some of those abnormal responses to the trauma the second go round. And he was, had laser-like focus in terms of getting back on the field, and was able to do so in 6.5 months and kind of help his team, win a championship. So, again, there could be success stories out there. We don't want to focus on all the bad stuff, but it's definitely a pleasure to take care of athletes, because they do have that dedication and are focused to kind of recover, and when you have that combined with a successful treatment plan, whether it involves surgery or not, it really creates a scenario where someone can have a great outcome. So I want to thank everyone for the opportunity to speak with you tonight, and we'll happily answer any questions.
Okay. Now we'll have some questions. The first question is for Dr. Stutzman. How can I differentiate between a minor hand injury and a serious one?
So again, I think the major point is that there's just times where you need to have an X-ray or an examination, and it's very hard. The initial injury obviously could be a simple sprain, and there could be a lot of pain. You ice it, you rest it, and I think bruising is a telltale sign that there's more to the injury than just a simple injury. Consistent pain, after even the first day or two, you're going to find that there's continued pain, but anything that has bruising on it is a telltale sign that something is a little bit more severe than just a simple tweak of a tendon or a ligament.
Thank you. This is for Dr. Weidenbener, sorry. Weidenbener. Sorry about that.
Right.
With kids and teenagers, parents often think you can't move it. If you can move it, it's fine. What's the best way to determine when to go see a physician?
Well, if you can move it, it can definitely be fractured. You can definitely have torn things. And again, as was pointed out, different athletes have different response to different injuries, different levels of pain tolerance. So I would guess observe, err on the side of caution for a day or two. If it's not getting better, I would have it checked out for sure.
And our next question is, how should female athletes address landing mechanics, drills, or training?
I think the best way to start with is to have the girls do some jumping and some landing in front of a big mirror. Let them see how they land. A lot of more competitive teams will do actually ACL prevention programs. They have not been completely successful, but it definitely does help to let them start to learn, do I have this issue? What can I do with it? So watching themselves land and then starting to work on hip abductor strengthening and just some of the small muscles around the hip is a great place to start.
And our final question for this evening is, what strategies do athletes use to cope with the physical pain of an injury?
I think I'll take that one. So the mechanisms that they use are, varied, but obviously icing is critical. So, any acute injury, there will be swelling of the joint, and elevation and ice is critical. Many of our athletes at, the collegiate level will use, ice compression units, sort of the commercially developed unit that will keep the limb at a sort of a 50-degree temp, so not too cold. It won't cause frostbite, but they can provide some little compression as it's icing and cooling the area, and that can be very helpful, in terms of pain management, surprisingly. Obviously, we'll use over-the-counter medicines like a combination of Tylenol and ibuprofen, and that can be alternated to kind of help with the acute, not only swelling, but pain. And then in, significant cases where there's a fracture or significant ligament injury, they may or may not need a day or two of a narcotic medicine, if pain is severe. But those are sort of our early modalities for treatment until we kind of know what's going on and have a treatment plan in place.
Thank you. Thank you to all of our physicians for speaking tonight. Additional questions will be posted in our OrthoAlliance OrthoInsights blog on the OrthoAlliance website. Thank you for participating in tonight's webinar. Our next webinar in our sports medicine series will be held on Wednesday, September 25th from 7 to 8 p.m. Doctors Aaron Basler, Jordan Bonnier, Nicholas Walla, and Alex Tansevsky will be speaking about sports-related injuries of the elbow, shoulder, hip, and knee. You can register for our upcoming webinars at orthoalliance.com/events. Please also consider liking and following the OrthoAlliance social channels for up-to-date information on our upcoming events. Thank you and good night.